Good evening, sir. Can you hear me, sir?
हाँ जी सर बिल्कुल.
Good evening, Dr. Manish, and good evening, everyone, for this new edition of our INOC DigiConnect webinar. This is our 68th issue, and today we all have connected to discuss on a new topic, that is the new paradigms in treatment of early resected epidermal growth factor receptor mutated non-small cell lung cancer. So, and the second topic is by our own Vice President AUSD, Dr. Rajiv Kumar Jain sir. That will be about the COVID Epid update, and this will be the regular update which we are having from Rajiv sir for the COVID and what is the situation, evolving situation, because it is the COVID situation which has united every one of us, connected every one of us, and with these learned faculties to learn from them. And today, as I've told that the learned faculty is Dr. Manish Singhal, and his topic, as I have told, this will be the new paradigms in cancer treatment. So this topic we have taken why, because I have discussed with Dr. Manish, because a lot of effective treatment and targeted treatment therapies now they are there in the market, and although many of them they are in experimental stage, but they are quite effective. So we as various public sectors, government organizations, and private corporates, we need to take a call on these treatment strategies, because these treatment they are definitely beneficial for the patients, and they can be delivered at certain specialized centers. Only thing is required is our government approval is mandatory for that. Otherwise, you have to do it on a trial basis, and that opportunity is also available with us. So, lot of targeted therapies, new drug carrier systems, theranostics, they are available, and we should know about each one of them so that we can take appropriate decision regarding the treatment of the patients which we are seeing in our day-to-day practice. To introduce Dr. Manish Kumar Singhal, he is DM, in medical oncology from All India Institute of Medical Sciences. And he is senior consultant medical oncology in Inpress Apollo Hospital, New Delhi. And Dr. Singhal, he did his MBBS from Seth GS Medical College, KEM Hospital, Mumbai, and MD in internal medicine from Rohtak. He got his formal training in medical oncology, as I told you, from All India Institute of Medical Sciences. And during this tenure, he was selected for training at Oriel College, Oxford, UK, and Barbara and Karnos Cancer Center, Detroit, USA. His expertise spans in all types of chemotherapy, intensive protocols, immunotherapy, hormone therapy, in addition to dealing with oncological emergencies, including medical care of the patients. And he is also a member of executive committee of medical and pediatric oncology, which is a national body of senior academicians of India, and he is joint secretary for National Capital Region Oncology Forum. And he also have deep interest in breast cancer, lung cancer, gastrointestinal cancer, and lymphoma and leukemia and myeloma. So with this great background, may I request Dr. Manish Singhal sir to start his deliberation on this particular topic which we have chosen today, because it is the opportunity to learn a lot from you all regarding the newer modalities, so that we are well versed with the treatment modalities about the cancer treatment. Dr. Manish, please.
Yeah, sir. Thank you so much for your kind words. And I'll share my screen. I hope the screen is visible.
Yeah, yes.
Please allow to make it full screen. Is the screen moving also?
Yeah.
So as has been highlighted by Dr. Sandeep, the topic is newer modalities of treatment in newer paradigms of treatment in resected early lung cancer. As we all know that, stage 1 or stage 2 lung cancer, which are by far resectable, have been fairly less number of patients are detected in stage 1, stage 2, which is resectable, which can undergo surgery. And this remains the most curative treatment. And as you can see that stage 1 is a singular lesion which is not affecting any lymph node, whereas stage 2 is multiple lesion which may be affecting small lymph nodes. And stage 3 is when it moves up into the mediastinum, as is evident over here. So mostly stage 3 tumors are considered non-resectable, but stage 1, stage 2 are resectable tumors. But as the awareness is increasing, the number of resectable tumors, even in lung cancer, is definitely increasing. So we are definitely getting a few patients now, which are fairly early and are resectable. As far as recurrence rates are concerned, despite the fact that, even if you detect a lung cancer which is fairly early, a majority of the patients would recur. In a stage 1 patient, about 50% would recur, whereas in a stage 2 patient, about 60% of these patients would recur in the next 5 years. Whereas in stage 3, the recurrence rate is about 76%. That means we are not able to cure a majority of the patients, even if we detect them fairly early. So the disease recurrence rates are still quite high, despite having a very early stage 2. So this is something which is definitely concerning. So there are a limited number of studies which have shown that the prevalence of EGFR mutation is similar across the disease stages. So it's not really dependent on whether the stage is early or late. That is a different thing, that most of the lung cancer are detected in late because the symptoms overlap so many other diseases such as tuberculosis, asthma, or any other disease. The symptoms are so very overlapping that it is very rare to find early stage tumors unless until there is an index of suspicion or somebody gets a radiology test for a simpler thing and then you detect the disease. So ardent efforts are being made to increase the survivability of early stage cancers, as this early stage cancers have definitely increased. I don't know whether it is known to others or not, but uh, FDA and various guidelines have approved lung cancer screening. And the eligibility for lung cancer screening is patients who have, or people who have, or individuals who have smoking history of 20 pack years, and low dose helical CT scan of the chest is to be done once in a year into 3 years. And so ardent efforts have been made because the early stage lung cancers are now increasing, and they're getting detected and they're getting resected. So, and about 30 to 40%, especially Asians, of these patients who are detected early would have EGFR mutations. And these EGFR mutation patients, other than undergoing surgery and chemotherapy, they had nothing else to be offered. But now we have a study where a targeted therapy is offered after they have undergone mutations or after they have undergone surgery and chemotherapy. So then one can offer them osimertinib, which is to be taken for about 2 to 3 years. So this is a DORA study, which is a very important path-breaking study, which was recently published. And what they did in this particular study was that patients who had stage 1, stage 2, or stage 3A, very early stage diseases, and were found to have EGFR mutation and underwent surgery, they were randomized to a drug called as osimertinib, because osimertinib targets the EGFR mutations and both exon deletion, 19 deletion, and L858R mutation in a 1:1 fashion versus placebo. And as I said, that majority of the patient, even in stage 1, stage 2, and stage 3, would recur. 76% would recur. So it is very heartening to see the survival curves of this particular study, that how apart it can, a simple intervention or oral tablet can actually make survivals so much better. So when I come to the Kaplan-Meier survival curves, it is so very heartening to see the survival rates and the possibly the cure rates in these patients. So these are the inclusion criteria, exclusion criteria, very standard criteria, nothing majorly to dwell on this. So this was the profile of the patients. It was more females, because we know that females are never smokers as compared to males, or light smokers. And it is in non-smokers or light smokers where you see EGFR mutations. And as I said, that the EGFR mutation was well balanced between the two mutations, exon 19 and L858R mutation. Majority of the patients did receive chemotherapy, followed by the study drug, that is osimertinib. And these are the survival curves. As you can see that how much improvement has occurred in the survival of these patients. Can you just appreciate the recurrence-free survival, which is achieved with the drug? How much recurrence-free survival you can achieve with the drug? How apart they are? Almost, 70, 80%, more than 80%, 83% improvement in the risk of disease-free survival. Almost 83 to 80%, depending on the stage to stage. So 80% improvement in survivability without any disease recurrence is something which is never heard of in lung cancer. So much improvement, almost 80% patients are surviving, if you can see, at 36 months, as compared to only 20% patients. Such stark improvements in survivabilities is something which has never been heard of in the history of lung cancer. 83% and 80% improvement. So the 2-year disease-free survival rates, everything is there in front of you. You can see that, the curves by themselves, they speak. And these are the forest plot, and it shows that the point estimates are well in favor of the treatment arm, that is osimertinib, and the 95% confidence intervals are also well laid, and they are not crossing the unity line. So be it whatever be the subset, Asian patient, non-Asian patient, smoking history, no smoking history, age, sex, whatever mutation, chemotherapy, no chemotherapy, every subset is benefiting equally. This is the survival curve. That was the disease-free survival curve. This is survival curve. You can see that it is almost reaching 100%. In osimertinib, it is 93%. Because once the disease recurs, the patient doesn't die. The patient is offered second-line therapy, third-line therapy. So it takes a while for the survival curves to separate out. But the disease-free survival curves are well separated. And mind you, this is not the only time that an attempt has been made to improve survivability among lung cancer patients who have received surgery. Nth number of studies have it. Select trial, the Radiant trial, the Ivan study, the BR19 study, the adjuvant CTOM trial. None of these studies have shown any major benefit, because these studies have been carried out in different parts of the world, but they were still grappling with finding suitable candidate which can be offered to these patients who have received surgery. None other than this particular study has led to an improvement in the survivability. So it makes a compelling ground for approving authorities to offer to allow this medicine to be offered to patients to increase their survivability in case they find EGFR mutations and can be offered this therapy. Not only this, a very key consideration, which was the type of recurrence which happens in these patients. And we know that lung cancer is notorious to go to the brain. And if you look at the type of recurrence, this is the type of recurrence which happens. The distant recurrences are seen in 61%. And with osimertinib, you can see that the number of recurrences have decreased. The distant recurrences have decreased drastically. It is 38% versus local regional recurrences. So the number of distant recurrences are the ones which are most lethal, and they tend to decrease with the addition of osimertinib. Not only this, the CNS recurrences, which is around 10%, decreases to 1%. And we know that CNS disease, central nervous system, brain metastasis, results into major problems in a patient's life. And this is also tackled well with this intervention. So CNS recurrences are decreased, deaths are decreased, and the CNS disease-free survival is also improved in patients in the overall population. Adverse effects are not much. It's a very well-tolerated therapy. More than 80% patient will not have to stop the drug or stop the drug because of adverse events. It's fairly very well-tolerated. The usual side effects are diarrhea. But if you look at the severe toxicities, there's a grade 3, grade 4 toxicity, which is in dark blue. It is hardly 2%, 1%, pharyngitis, stomatitis, and all that stuff. So mostly these toxicities are well-tolerated toxicities. Diarrhea is something which does happen in some patients. And I think Dr. Sandeep would agree with me that there was a common patient between both of us who was prescribed this particular medicine, and they had this issue of diarrhea. And the patient actually could not take that drug quite well, the osimertinib. And I'm sure Dr. Sandeep would remember that patient. So I had not prescribed that medicine. Some other doctor had prescribed, but the diarrhea became a major issue. So sometimes it can happen, but the incidence of grave toxicities which results into stopping of the drug is just 2%, 1%. So these are rare, but we agree that it happens. It happens sometimes. So post-operative chemotherapy use and outcomes from ADAURA trial. It has been said that adjuvant chemotherapy, one may actually skip the chemotherapy, not even require any adjuvant chemotherapy, and still the benefit would be seen with or without any chemotherapy. Yet, if there is slightly advanced stage, I think the chemotherapy should also be given in addition to this drug, and the drug will follow the chemotherapy. And despite the use of chemotherapy versus no chemotherapy, the survival benefit remains. The question that cannot be answered over here is whether chemotherapy did anything better, whether we can actually forego chemotherapy in such patients who are tested EGFR mutation positive. That question cannot be answered here in this particular study. So without any hindrance from chemotherapy, despite chemotherapy was used or not used, there was survival benefit with the addition of the osimertinib arm. And these are the survival curves which are very evident and very evident survival curves. So patient-reported outcomes is very important nowadays, because patient-reported outcomes have become important. Has become an important endpoint for drug approvals. So now US FDA, various FDAs have started asking for patient-reported outcomes, because they want that the patient should report their outcomes. And the patient-reported outcomes are here. It shows that the patient compliance rates and everything was well maintained. So It was as good as placebo. There was hardly any detrimental effect on an average scale as far as patient-reported outcomes are concerned. So patients were happy taking the drug. They were not festered with by taking the drug. So to summarize, simple drugs, though expensive, I agree that it's expensive, that the first adjuvant therapy in targeted medicine has led to unprecedented results as far as the disease-free survival is concerned in resected lung cancers. And overall, there has been more than 80% reduction in the risk of disease recurrence or death. And osimertinib improves the disease-free survival quite much, including some improvement in overall survival, as also the control over the CNS disease. And I hope that the screening program, and we keep a low index of suspicion to judge whether a patient can be detected in an early stage, and they can be subjected to surgery. And in case they are carrying some mutation, they can be offered drugs like this. And this has become an ardent area of interest, not only for EGFR mutation. Now people are considering targeted therapies for ALK mutation, ROS1 mutation. Recently, we had a doctor, a gynecologist, who hails from Agra. She was detected to have a stage 3 lung cancer. We gave her chemotherapy, we down reduced it. And lo and behold, the patient had a ROS1 mutation. Now, ROS1 mutation is seen in only 1% of total lung cancer patients. She underwent surgery recently. She has recovered from the surgery. Now she's undergoing medicinal radiotherapy. And after this, we are likely to offer her crizotinib, which is a ROS1 inhibitor. It's a drug which is used only for stage 4, but now taking the corollary from what we have seen in ADORA, I think such patients can be offered targeted therapies to increase their, because the risk of recurrence is more than 70% in stage 3 and more than 50% in stage 2 and around 50% in stage 1 also. With that, I'll hand over the proceedings back to Dr. Sandeep, and over to him. Thank you very much.
Thank you, Dr. Manish, for giving an overview of this particular adjuvant targeted chemotherapy regarding this ADORA or the trial or the osimertinib. It is giving a very promising outcome with 80% improvement in the disease-free survival. And what is important is distant recurrences also, they decrease drastically. Now, what is important for every one of us, number one, early detection of cancer, so that the lung cancer, it is detected as early as possible. And that as an industrial physician, that we have to ensure through our various type of medical checkups and proper examination and early surgery for this particular patient. Then second most important thing is how we can make such an advanced treatment accessible to our patient. Because the problem which we have discussed with you earlier also, that such treatments are no doubt available, but problem is our medical rules, they don't permit them. Even the government of India, drug controller, they have given the permission only on trial, to be used on trial basis only. So what is your guidance for making this advanced treatment accessible to our patients? Dr. Manish.
I think, sir, an effective therapy, if available in the country, cannot be denied to a patient. I understand from where it is coming. It is coming from that, how to make a healthcare policy which treats everyone alike and yet covers for most patients, because the budget is limited. The health budget is limited. So I think for certain therapies, there can be some assistance programs. Assistance program is usually what the drug company does is, if you have a panel, say for example, the BHEL panel or Indian Oil panel or some panel, they don't give them the benefit which they give to patients who have out-of-pocket expenses, right? Who are paying out of their own pocket. Because those who are paying out of their own pocket, they get 1+2 free. That means they buy 1 month medicine, they get 2 months of medicine free. Something like that is the program. Whereas this is not done if you are if they see that on the billing sheet, it is BHEL or something like that, that is not offered the patients. So I think the only way to circumvent this is having a copay system. So some assistance come from the drug companies, some assistance come from the Indian Oil and all these PSUs. So one does not mean, it should not be all or none. या तो करेंगे तो पूरा करेंगे, वरना कुछ भी नहीं करेंगे. So अगर कोई patient ICU में चला जाता है, what is his outlook? एक patient काफी sick है, वो ICU में चला जाता है, वो 1 करोड़ रुपए खर्च हो जाते हैं उसके ICU में, 50 लाख रुपए खर्च हो जाते हैं, and finally the outlook is, or the outcome is 0%. Because if the patient is very sick, you may end up spending 50 lakh rupees on his treatment with the probability of coming out, or the probability of survival being less than 2%, less than 5%. Sometimes with multi-organ dysfunction, you would agree with that. But we are ready to take that brunt of 50 lakh rupees when the outlook is like 5%, but we are not ready to accept a 80% improvement in survivability and reimburse that thing, because we know that as per the given evidence, there's going to be 80% improvement. So rather than having an all or none phenomena, I think it is important that some assistance should be there. Whenever a copay system will be introduced into the system, then the drug company will also give them assistance, because it's not 100% reimbursable. So I think PSUs should have some system of copay where the level of assistance may change depending on what type of treatment they are undertaking. This is my thoughts. Of course, these are very personal thoughts, which may or may not be adoptable immediately. But my thoughts are that it should not be all or none.
I mean, definitely, the person who requires it, they should get the treatment, and maybe through any means, by assistance program or through.
If they're a beneficiary of a government organization, should be based on some assistance, if not 100% assistance.
Right. So this was regarding the treatment part. What another request was how to diagnose lung cancer early. As what is your advice to?
So my advice is very simple in this. There is no one good symptom of lung cancer which can clinch the diagnosis of lung cancer. So in case you have a patient who is a smoker, of course, your index of suspicion will be lower. But the lung cancer symptoms are very overlapping with so many other commoner illnesses. So cough, weight loss, mild fever, breathlessness. I think it is important that all these symptoms should not be ignored. In case these symptoms do not become better after your working diagnosis may be acute bronchitis, and patient doesn't become better, say in next 7 to 14 days, it is better to investigate more. I think at the outset, the patient should be told that I am writing you medicine for 7 days. If you don't get better, come back to me. Let the patient not come back. That it is vicarious liability. It is what do you call it in forensic medicine? You call it shared responsibility, something they call it. So it is the responsibility of the patient to come back in 7 days, if no improvement. Because many a times what happens is that when patients come to us, they say that हम तो डॉक्टर के पास गए थे, उन्होंने diagnose नहीं. So the blame is on us as doctors. Whereas when they come to me, I always tell them that, see, there are so many overlapping, symptoms. अगर आपको headache है, तो normal migraine भी हो सकता है, blood pressure high भी हो सकता है, eyesight की problem भी हो सकती है, brain tumor भी हो सकता है. अब हर headache के लिए तो हम MRI नहीं कराएंगे ना. अगर headache ठीक नहीं हो रहा है, तो आप MRI कराओगे. तो मुझे नहीं लगता कि डॉक्टर की गलती है, but then patients always tend to think like this. So it is important that if you have made a working diagnosis after seeing the patient for the first time. If you expect that the patient should get better in 7 days, 10 days, 15 days, and the patient is not getting better, please tell them at the outset that if you don't get better, come back to me. I would like to investigate you like this. And a good history taking and a good physical examination will reveal the diagnosis. But if you have done all this, you have taken a good history, You have taken you have done a good physical examination. You have done rightful investigations. It is very rare to miss it. It is likely that you miss it. And the proper investigation means tissue diagnosis. Many a times doctors, they shy away from tissue diagnosis. Pleural fluid किया निकाला उसमें cell नहीं आया तो it's not the malignancy. By pleural fluid में catch rate is about hardly 40%. We know that there is a dilutional effect in the pleural fluid, so the catch rate for malignant cells in the pleural fluid is just 40%. That means 60% malignancies will be missed if you disregard if you disregard pleural fluid cytology being negative. So it is important that these steps should be done.
So our clinical acumen, that is most important, followed by the investigations, and we should be clear that
and keep malignancy as one of the differential diagnoses in today's world.
Yeah, and especially the history is very important, and the history of the work environment, that is also very important. And in this regard, may I request Dr. Vivek Chandra sir, because he has a lot of experience about this, because he is working in such an industry and he has worked a lot in all this pneumoconiosis and other things. Dr. Vivek Chandra sir.
Yeah. Good evening, Sandeep. Good evening, Dr. Singhal. Good evening, everybody. Thank you very much for raising this question. But what I would like to say that we occupational health physicians, we practice preventive medicine. So all occupational, I mean, in the setup which where I am working, it's an asbestos cement industry, where the environmental control conditions have reduced the dust levels to such a low level, and we can prevent all either pneumoconiosis or asbestos-related lung cancer, and the type of fiber which we are using that prevents mesothelioma also. So we have hardly seen any case of lung cancer with pleural plaques and asbestosis to call it as asbestos-related lung cancer. But as Dr. Singhal has explained, it's very pertinent, I mean, to call back the patient. That's more important. We occupational health physicians, we face this challenge, and we are blamed unnecessarily, because when we examine the patient physically, when we do some preliminary investigations, it's always necessary for us to ask them to come back, and it is essential for us to follow up them till we clinch some diagnosis or the patient improves thoroughly. Thank you, Sandeep. That's my observation.
Thank you, sir. Rest of the panelists, if they have any question, they can raise their hands or they can unmute themselves, and they can. Yeah, Dr. Tyagraj, sir. Dr. Tyagraj from Bangalore. Logged in from two devices.
Good evening, Dr. Singhal, sir.
Yes.
Hello, sir.
I have a question that. Thank you, sir. Thank you, sir. Sir, in case if you wanted, when we diagnose the cases of lung cancer, what exactly we do is we refer to this cancer hospital. Once if they go there, they will be after coming to know through the MRI or anything. We usually refer the cases, that suspected cases of lung cancer, to the hospital, lung cancer hospital. There, the first one that they will do is they will do the surgery, and after the surgery, sometimes they recommend for chemotherapy, and this newer targeted therapy, like the third generation hospital, how to identify this patient needs chemotherapy, and also newer third generation drugs like this, how to identify, sir? This is number one question. Number two is we have read in literature that immunotherapy also is a very good in a advanced stage of cancer. This immunotherapy also will be very helpful. Will you please throw some light on these things, sir?
Right, sir. So there are two questions. How do we identify whether the patient would require a targeted therapy? So for that, sir, you need to do mutational analysis, which is a DNA analysis of the tumor. And so the tumor which has been dissected out, or the initial biopsy which was there, has to be subjected to a DNA analysis to see whether which mutations the tumor is carrying. In case they are carrying a mutation, then they are eligible both for chemotherapy followed by the targeted therapy. So that answers point number one. So mutation analysis is important. Immunotherapy is not yet approved in early stage lung cancer. There are a lot of new studies which are going on. So we have to wait for those studies to take place. But yes, you are right. Immunotherapy is approved for stage 4 lung cancers. That is, we had a discussion on early stage lung cancer where surgery has been done. But post-surgery adjuvant, that is preventive immunotherapy, is not yet approved. There has been a few papers which have come out for preventive immunotherapy. That one is in esophageal cancer, one is in stomach cancer, where immunotherapy as preventive for recurrence has been approved recently by FDA, and also in bladder cancer, that is urinary bladder cancer. Recently, they have also been approved for kidney cancer. 1 year of immunotherapy has to be given for stomach cancer, GI cancer, kidney cancer, and bladder cancer, where immunotherapy has resulted, but not yet in lung cancer. But definitely studies are on way. We may find that some positive results there also. But immunotherapy for late stage lung cancer is approved.
Thank you, sir. Thank you very much.
Dr. Puneet Chandna, sir.
Hello, good evening, Dr. Singhal. How are you? And
all well, sir.
Thank you very much. All right. So if I may ask you that so far, how we are looking at the other mutations and the targeted therapies in the government setting, which is the ML4 ALKs and the ROS, specifically the crizotinibs and so on. Because osimertinib, I can understand. Yeah.
It is difficult to talk about that because or research on that based on adjuvant settings. But ROS1 and ALK mutations are fairly uncommon. 1%, 2% of ROS1 chance, 5% for ALK mutation. So it is difficult to accumulate as many patients in a randomized controlled trial to show the benefit of ROS1 or ALK mutation. EGFR is about 30 to 35%. So it is easier to do. So ADAURA study was still conceptually feasible, but to do a study for ROS1 and ALK mutation will be difficult task, because to accumulate as many patients in early stage lung cancer, then they are resectable, and then they are randomized to crizotinib versus no crizotinib. I think such a study would be very difficult to conceptualize. Yet, I think one can take a corollary from the studies and from what we understand of crizotinib in late stage lung cancer and offer them crizotinib. As I just explained that we had a gynecologist who was recently detected to have a stage 3 lung cancer, underwent surgery, and now we are planning to give her crizotinib for about 3 years. We have discussed with her that there is no data. We have discussed the ADAURA trial data with her. She's a doctor herself. She says, I want crizotinib.
Right. And my follow-on question, just a quick one, is now we are talking about the biopsies, usually, which will help us get the tissue or, for the mutation analysis. So what is the advice? Because we normally see that the patients undergo the surgery, and if the targeted therapy becomes incidental, approved by the government of India or for patients, whatever, they don't have a block. And if they have a block, which is an FAP block, the amount of biopsy in lung cancers in early stages especially would be very small. So where would you advise it to be used, for the immunohistochemistry or for the mutation analysis, as per your experience? Because we see, we cannot revive a lot of DNA from there. We have a good genetic testing.
So, sir, if there is hardly any confusion on diagnosis, say it is clear-cut lung cancer, there's no confusion. So I think we can forego the ISC and do only mutational analysis and not waste the tissue, because there's hardly any substitute for a mutational analysis. In case there is a diagnostic dilemma, so you have to subject the biopsy through immunohistochemistry and then do the mutation analysis.
Right.
So I think this is how you would triage the block. One option of doing mutational analysis is also liquid biopsy, that is circulating tumor DNA. That can also be subjected to mutation analysis, but it is fraught with its own limitations, which is in about 40% patients, you may not detect a mutation where it would be present in the main tissue or the tumor block.
Right. And thank you very much. Very well said. As a medical oncologist into a large setting hospital, would you recommend low density CT to be coming up as a screening technique for at least the higher risk patients?
Sorry, I didn't get that.
The low density CT you were talking about for the early stage cancers, would you?
It's not into practice. It's not into practice.
No, from your experience, would you love to have it as a?
I would love to have it. I need to know the smoking history. You know that patients don't give their smoking history. आप किसी lung cancer patient को बोलो कि cigarette पीते थे, कि छोड़ दी. They will never say कि कितने दिन तक पी.
Right.
And they will shy away from that because that's the guilt, that inner guilt they don't allow. But in case there is a well-informed person who says, yes, I've been smoking and I've got a 20-pack year history, I don't shy away from offering them low-dose helical CTs.
All right, fair enough. Thank you very much.
Right, sir. Thank you.
Dr. Manish, there are two questions only from the Q&A box. One is the life expectancy in malignant CA lung with chemotherapy and immunotherapy biologicals. This is from Dr. Ghanshyam Tulera from Mahape. Yeah.
So, sir, life expectancy, as I said, that in today's world, stage 1 life expectancy is about 40% to 50%. If they are EGFR mutation positive, it can rise to around 80%. And stage 2 would be stage 1 is about 60%, stage 2 is about 40%, can rise to around 80% or so. And stage 3 lung cancer is about 25%, has increased to 40% because of immunotherapy, because now we are offering immunotherapy in stage 3 lung cancer, which are not resected. And stage 4 lung cancer, 5-year survivability is around 15 to 25%, depending on the mutation or whatever the mutation. So the ballpark figure is 15 to 25%, not cure rate. I'm talking of 5-year survival. Whereas stage 1, stage 2, stage 3 are potentially curable to the tune of 60, 40, 20%. Now these percentages are improving by at least 10% more.
Right. So if it is diagnosed early, then the cure rates, they are much more.
Much more, there's no doubt.
Yeah.
But even in stage 4 lung cancer, we are talking of 5-year survivability between 15 to 25%, which was 0% a few years back.
And with these new targeted therapies, if diagnosed early and resected early, then it may even give you 100% cure. So another question is from Dr. Damodar Lere, senior member from Mumbai. He's asking, is X-ray chest useful and what should be the interval between the X-rays?
So chest X-ray is not useful in various randomized controlled clinical trials where X-ray chest was used as a screening modality. It did not result into any improvement in survival.
So in this case, you would like to have low density CT.
Low density CT in an appropriate patient, and an appropriate patient definition is 20 pack years history.
Okay. And last question from Dr. M. Kulkarni. Is it good to do liquid biopsy as mass screening procedure in high risk environments?
We are not yet there, sir. But there is a lot of work going on in that direction, whether a liquid biopsy can judge that you are likely to develop cancer in times to come. So it is not ready for prime time. It is not ready for routine public use. We need more data on it. But a lot of work is going on.
So I think with this, sir, we have given enough of your valuable time regarding this particular topic. And we are all back to the basics: history taking, then clinical examinations, review of the patients again and again if they are working in some hazardous environments, or if they have some history, then early diagnosis is very important based on these criteria. And if it is diagnosed early, then it should be treated early. And now the science is giving us a lot of opportunities to give a cure to these patients. And we as occupational physicians or industrial physicians, it is our responsibility to be aware of these sort of treatments and give proper guidance to our respective managements so that right treatment can be given to the right person. So with this, I thank you very much, Dr. Manish Kumar Singhal, sir, for this
Thank you, sir.
nice talk, and we'll keep in touch, sir. Thank you very much.
Right.
And with this, we come to conclusion of the first session, and the second session is by our own Vice President AESD, Dr. Rajiv Kumar Jain, and he is coming up with the COVID Epid updates. And these COVID Epid updates, they have helped all industrial physicians across India to take mitigation measures in their respective industries regarding COVID, be aware of the COVID evolving situation. And we are getting the authentic news from the authentic sources, and that is all compiled by Dr. Rajiv Kumar Jain, sir. And Dr. Rajiv Jain is our Vice President of the AUSD, and he is a very senior member from the AUSD faculty. And may I request Dr. Rajiv Kumar Jain, sir, to start his presentation.
Thank you, Dr. Sandeep. Good evening, friends. Here we are again on a Saturday evening, trying to understand the current epidemiological situation of COVID-19, as we have done for the last so many weeks, because we are concerned about the epidemiology of COVID-19, and we are concerned as a subject to learn epidemiology for our practice of occupational health and occupational medicine. Because without this, one would not get a lifetime opportunity to learn the science of epidemiology. So let's try to get the information and the interpretation attached to that information regarding epidemiology of COVID-19. Let's see the first slide. Next slide, please. Well, this is a slide where you get an overview of the global situation of COVID-19. The graph below is showing a black line, that is the death, the cases where people died, while the overall graph is for the cases with different colors. Colors represent the different regions of the World Health Organization. Yellow is Americas, violet is Southeast Asia, green, light green is Europe, dark green is Eastern Mediterranean, blue is Africa, and purple is Western Pacific. So what you see the third global wave and the fourth global wave of deaths. Globally, the number of new cases reported this week remains similar to that of the previous week, with over 4.4 million new cases reported this week. The global evidence incidence of COVID-19 cases has remained stable over the past month. In the past week, all regions reported either decline, like regions of Africa, Southeast Asia, and the Eastern Mediterranean, or a similar trend in new reported cases as compared to the previous week. That is the regions of Europe and Western Pacific. The regions of the Americas reported 19% increase. You're seeing the yellow, that proportion has increased by 19% in a week. So only the Americas has shown increase in the past 1 week in terms of cases. Number of deaths reported globally this week was also remained similar to the previous week, with just under 68,000 new deaths reported. The incidence of new deaths declined in all regions apart from the region of the Americas and Europe, where deaths increased by 17% and 20% respectively. Regionally, the largest proportionate decrease in new deaths this week were observed in Southeast Asia, with 21% decrease, and African 26% decrease, while the regions of the Western Pacific 8% decrease and the Eastern Mediterranean 14% decrease also reported notable declines as compared to the previous week. The cumulative number of cases reported globally is now just over 220 million. And the cumulative number of deaths is over 4.5 million. Next slide, please. This is the figure in actual data form. Change in new cases in the last 7 days. As you're seeing, Americas has shown 19% increase in cases, and Americas has shown 17% increase in deaths, and Europe has shown 20% increase in deaths. And all other regions have shown decrease in number of cases and decrease in number of deaths. Next slide, please. This is the graph of the different regions. Earlier you had seen the global graph. Now you're seeing WHO regions graph. The yellow graph is for the region of the Americas. The black line is all the graphs is the line of deaths. And the bars are in the color are the cases. So what you see USA, the Americas are showing the fourth wave, and the deaths are also in the fourth wave. European region is also showing the fourth wave and also the fourth wave of deaths. African region is in the third wave of cases and deaths. Eastern Mediterranean region is showing a different graph where each each spike is followed by a higher spike, and it is showing if you see first, second, third, and the fourth wave is on at the moment in Eastern Mediterranean region. But look at the Southeast Asia region. What do you see? You are seeing the third wave in the Southeast Asia region and the third wave of deaths. Now just look at the Western Pacific, the bottom right. It is showing a series of waves, each wave, subsequent wave, higher than the previous wave. So what you see, how many peaks you are seeing? 1, 2, 3, 4, 5, and 6. The sixth wave is the highest wave at the moment in the Western Pacific region, mainly Australia. While the Southeast Asian region is mainly India. Eastern Mediterranean region has all the Islamic countries. African region is a very wide country, but the number of cases, number of deaths is low. So it may be showing further waves and series of waves. That's the real situation in the WHO regions of the world. Next slide, please. This is in terms of cases during the last 24 hours and during the last 7 days. So last 24 hours, there were 5,84,000 cases in the world, with highest cases of 2.24 lakh in Americas and 1.68 lakh in Europe. This is last 24 hours. But if you look at 7 days, out of 40 lakh cases reported, 14 lakh were reported by Americas, and Europe reported 11 lakh 41,000, while Southeast Asia reported 4 lakh 86,000, and Western Pacific reported 5 lakh 9,000. So last 7 days, Western Pacific has overshot Southeast Asia. If you look at the deaths, last 24 hours, out of 8,000 deaths, 3,351 deaths occurred in Americas, 1,978 in the Europe. So the deaths are occurring primarily in Americas and the European region of the WHO. If you look at the deaths in the last 7 days, out of 62,000 deaths, 23,000 deaths occurred in Americas and 14,000 deaths occurred in Europe, while only 9,300 deaths occurred in Southeast Asia and 6,414 in Western Pacific. Let's see the next, let's just go to the next slide. This shows the country-wide ranking, the top 10 countries in terms of cases in the last 24 hours and in the last 7 days. Out of 40 lakh cases reported in the last 7 days, United States reported 10 lakh, India reported 2,71,000, United Kingdom 2,69,000, Iran 1,82,000, Turkey 1,54,000, and then Philippines, Malaysia, Russian Federation, Brazil, and Thailand all have reported more than 1 lakh and less than 1.5 lakh cases in the last 7 days. So the pandemic is very much there in the world. All continents, all the countries across the continents, and all the regions of the WHO. Next slide, please. Let's see the condition where from the deaths are coming. Out of 62,000 deaths in the last 7 days, United States reported 10,495 deaths, and Russian Federation reported 5,554, Mexico 4,900, Iran 3,900, Indonesia 3,500, Brazil 3,200, Vietnam 2,300, Malaysia 2,200, and India 2,114, Turkey 1,887. So again, the same story reported in terms of deaths. They are into all continents, and all countries are representing their contribution in the top 10 in terms of deaths during the last 7 days. Let's see the next slide. This is a global picture of cases per 1 lakh population reported by the countries. The darker the color, more has been the cases per lakh in that population. And you find the dark brown in all the regions and all the continents of the world. Whether you are seeing in Americas, or you are seeing in Asia, you're seeing in Europe, and you're seeing in Western Pacific region as well. And you are even seeing in African region as well, the northernmost portion and the southernmost portion of the Africa. Next slide, please. This is the picture of the world in terms of deaths per 1 lakh population reported by country. Darkest blue is the highest death, and green is the lowest number of deaths per 1 lakh population. So you see the dark blue is across the world, whether it is Americas or Europe or Southeast Asia or even Western Pacific region. Look at Sri Lanka, just below India. It is in dark blue. And if you see in Africa as well, in northernmost part of Africa is dark blue. And even in Europe, there are countries which are dark blue. So all countries are affected in terms of deaths. Next slide. This is the picture of Southeast Asia region. The Southeast Asia region reported over 4.543 lakh new cases and over 11,000 new deaths, and decreases by 9% and 21% respectively as compared to the previous week. Despite the overall regional decline in case incidents, India, Myanmar, and the Maldives reported increases in the number of cases of 8%, 24%, and 43% as compared to the previous week. The highest number of new cases were reported from India, 2,93,000 with 8% increase, Thailand, 1,06,000 with 15% decrease, and Indonesia, 55,000 cases with 42% decrease. All countries except for Sri Lanka and Timor-Leste reported decreases in weekly mortality by more than 5%. The highest number of new deaths were reported from Indonesia, that is 3,938 with 29% decrease, India with 2,700 new deaths with 22% decrease, and Thailand with 1,700 new deaths with 6% decrease. And you are seeing the graph, and graph clearly shows the third wave is on in the Southeast Asia region, and in terms of deaths also, the third wave is on at the moment in Southeast Asia region. Next slide, please. This is the COVID India 19 India snapshot. Last 24 hours, 37,870 new cases, 310 deaths, and 16.9 lakh tests done yesterday. 7-day average test positivity rate is still above 2%, that is 2.2%. 3.87 lakh active cases are there, shrinking by -0.43%. Total had been 3.32 crore cases, 4,42,350 deaths have been reported. And on the positive side, 73 crore vaccination doses were given, but only 57 lakh doses were given yesterday. Next slide, please. This is the India summary. Confirmed cases out of 37,000 total cases, Kerala contribute 25,000, Maharashtra 4,000, and Tamil Nadu 1,600, Andhra Pradesh 1,600, Mizoram 1,055, and Karnataka 967. Amongst the deaths, out of 310 deaths, Kerala contributed 177, Maharashtra 44, Tamil Nadu 25, West Bengal 14, and Karnataka 10. Tests per million per day, the highest is in the country are being done by Mizoram, 8,000, Andaman Nicobar 4,700, Kerala 4,200, Jammu Kashmir 4,067, Delhi 3,700, and Pondicherry 3,700. But on the other hand, look at the bottom. Rajasthan is only doing 321 tests per million per day. West Bengal only 440. Chhattisgarh 674. Madhya Pradesh 793. So they need to do more tests to understand their situation of COVID-19 in their state. If you look at 7-day average test positivity rate, Kerala is showing the highest 16.9%, Mizoram 12.8%, Sikkim 9.3%, Manipur 8.2%, Meghalaya 5.4%, Andhra Pradesh 2.2%. Indian average is 2.2%. If you look at the 7-day average daily growth percentage, Mizoram is having the highest 1.55%, Kerala 0.62%, Meghalaya 0.25%, Manipur 0.23%, Nagaland is 0.15%, Indian average is 0.11%. If you look at the vaccinated persons with at least one dose in terms of percentage, India is 14.91, while Bihar is only 29.29, Jharkhand is only 30.26, Nagaland 30.45, UP is 31.21. So they need to buckle up and they need to increase the vaccination with at least one dose because they have the highest percentage population without not having received a single dose of vaccine. Next slide. This is the 7-day average new cases. They are still on rise in Mizoram, while still they are falling in Kerala and Maharashtra. In both Madhya Pradesh and Pondicherry, there's an increase in daily new cases and the test positivity rate, that is 7-day average, although the numbers itself are too small, show up on the chart. But if you look at the trend, you are seeing a different kind of picture in each state. So what does it mean? It means one needs to assess the situation on the ground in respective state and respective district and act on that. Next slide. This is a positive graph relating to vaccinations, and this is the trend in daily COVID-19 vaccinations in India. Total, we crossed 1 crore mark 3 times. 7-day average is at 8.4 million and rising. Need 10.26 million per day to fully vaccinate all adults by the year end. We might most likely be able to vaccinate all adults with at least a single dose by the year end, barring possible hesitancy by a few. If you look at the blue, they are the daily new doses. Second dose is in gray, while green line is 7-day average moving average, both doses, and yellow line is 7-day moving average of first dose. And it is rising and rising. And that's a good news. If we maintain the current trend, we will be able to meet our target of meeting the target of 1 dose to all the adults in our country by the end of the year. And we just need to do more than 1 crore doses every day. Next slide. This is a global picture of countries reporting variants alpha, beta, gamma, and delta. And if you are seeing the condition, alpha is in 194 countries and also present in India. Beta is in 141 countries. It's also present in India. And gamma is in 92 countries and is also present in India. And delta is in 174 countries and it is also present in India. So India has all the 4 variants of concern. Next slide. This is the current latest summary of impacts of variants of concern. If you look at delta, it's still showing increased transmissibility and secondary attack rates, disease severity, increased risk of hospitalization, risk of reinfection, reduction in neutralizing activity reported, impacts on diagnostic, none reported to date with respect to delta. Next slide. This is the summary of vaccine performance against variants of concern. And if you look at AstraZeneca vaccine, it is showing neutralization between 10 to 20%. Beta is showing neutralization 10 to 20% again. Gamma vaccine efficacy is 10 to 20%. Delta is showing 10% to 20% neutralization. Next slide. This is the new development which has occurred this week, faster and easier verification. A new digital tool has been launched by National Health Authority, that is COVID, and it allows verification of a person's vaccination status without disclosing the certificate. How it will work? First is people will need to share their phone number, register on CoWIN with the institution or entity that want to verify their vaccination status. Second is the number will be fed into the application programming interface, which is API, which will then send an OTP to the person whose status has to be verified. And the final third is once the person shares or enters the OTP, the vaccination status will be directly sent to the institution or entity for them to verify. Potential use will be by workplaces for employees returning to office, in railways, airlines, and airports for online passenger booking or reservations and entry into the premises of railways, airlines, and airports, and hotels for guests at the time of checking in or online bookings. Benefits are it's easier to check the status, requires consent of individual, and does away with the need to show certificate, which displays more personal details. But there are concerns as well. Concerns are questions about digital access and information to India's vastly diverse population are likely to persist. Next slide, please. This is another interesting data which has come through genome reports. They detail rapid spread of Delta variant in the city in the months between February to July 2021. And you see the Delta variant was identified in India December 2020 and has subsequently been detected in over 95 countries. And what you observe, the maroon color, the dark red color is Delta variant B16172. In April, it was 54%. May, it became 81%. June, it became 88%. And July, it came to be 90%. So it dominated. While earlier, if you see February, only 6% was alpha. February, 19% alpha. March, 47% alpha. But it became, in April, 12% only. So it was replaced by Delta variant, and Delta variant brought havoc. It led to huge hospitalization rates, huge number of deaths, huge ICU admissions, and everybody knows in our country what happened during May-June period. Next slide. COVID positivity rate is still high in 69 districts. India's COVID-19 test positivity rate, or the share of tests turning positive for the virus, dropped to 2.4% this week from the second wave peak of 25% in late April. However, the figure still exceeds the critical 5% threshold in 69 districts in the country. These districts are spread over 12 states and union territories, mostly Kerala and the northeastern states. Of the 69 districts, 36 have a TPR above 10% and 7 are above 20%. Worryingly, in 49 of this district, the ratio has worsened in the last 2 weeks. Our positivity rate below 5% indicates that the infection is under control. This reflects in rising public mobility and economic activities, with the Nomura India Business Resumption Index returning to pre-pandemic levels last month. Reducing the TPR below 5% across India will help recovery become more broad-based. 9 of the 10 districts with the highest growth in TPR are from the Northeast, which otherwise has relatively fewer active cases. As well in Mizoram, which is the most active cases in the region, 7,087, saw its TPR go up by 7.4 percentage points in the last 2 weeks. Ernakulam and Kozhikode in Kerala, which have over 30,000 active cases each, saw their TPRs go up 3.6 and 2.5 percentage points respectively. In addition to COVID-19, Kozhikode is also fighting the threat of Nipah virus, which killed a 12-year-old boy last week. The Maharashtra has 3 districts with high TPR. Pune, 12,064 active cases, saw its TPR grow by 1.3 percentage points during the period. Next slide, please. This is the graph of country map, and on the right side, Kerala has shown 11 of the top 5 districts with highest test positivity rates. And the districts, as you see, Peren in Nagaland, Dibang Valley in Arunachal, Mon in Nagaland, Thrissur, Palakkad, Wayanad, Kozhikode, Idukki, Kollam, Malappuram, Alappuzha, Kottayam of Kerala, and Ukhrul in Manipur, Mahe in Pondicherry, and then Pathamtitta in Kerala again. So this is the current position visually visible to you. Next slide. Maharashtra's weekly death numbers have declined while Kerala have grew. India's weekly deaths have reported 30% in the last, dropped 30% in the last 7 days, the sharpest dip since the number started falling 10 weeks ago. 21 states and UTs reported deaths in the single digits, while 8 reported 0 deaths, a common trend for the last few weeks. The 5 states with the most deaths, Kerala, Maharashtra, Tamil Nadu, Karnataka, and Andhra Pradesh, had 83% share in the total deaths in the country the past week, compared to 80% a week ago. All 5, except Kerala, reported a decline this week. Maharashtra halved the number of deaths this week to 466. Among the 10 districts with the highest toll, 7 belong to Kerala. Kozhikode reported not only the most deaths, that is 162 among districts, but also a 51%, one of the sharpest increases since last week. It is followed by Thrissur and Palakkad, both of which reported a decline. Next slide. Himachal, Kerala, and Uttarakhand led large states in vaccination coverage. India's vaccination coverage grew by 5.7% in the last 7 days to 716 million doses so far. It crossed the 10 million doses a day mark 4 times in the last 2 weeks, most recently on 6th of September, when India administered 11.5 million doses, its second highest. India averaged about 7.6 million doses a day in the past week, almost 1.5 times that of the last month. Among the states with 10 million plus population, Himachal Pradesh with 996 doses per 1,000 persons leads in vaccination coverage so far, followed by Kerala with 859, Uttarakhand with 811, Gujarat with 796, and Delhi 780. All these states have been among the leaders since early April. 5 of the 8 northeastern states, Arunachal, Nagaland, Manipur, Meghalaya, and Tripura, have seen the lowest rise in coverage, each reporting a rise of less than 25 doses per 1,000 persons in the past week. Next slide, please. Indonesia overtook Bangladesh in vaccination coverage growth. Globally, Bangladesh ceded its top spot among the most populous countries to Indonesia in terms of weekly increases in their vaccination coverage. The Indonesian government accelerated its drive, partly due to 5 lakh AstraZeneca vaccines it received from Australia, the first installment of Australia's commitment to share 2.5 million doses. Indonesia has also approved 2 more vaccines for emergency use, that is single-dose jabs produced by Janssen Pharmaceutical and China's CanSino Biological Inc. Despite the relative slide, Bangladesh has increased its vaccination coverage. It launched a mass vaccination drive for the second dose early this week, propelled by the 1 million Pfizer doses that it received last week from COVAX. It is set to receive 5 million more doses in phases this month. Meanwhile, India has assured that its vaccine exports will resume soon, but did not commit to a timeline. Next slide, please. Let's also examine what has happened due to closure of schools. Learning issues persist as schools stay closed. With most Indian schools shut for the past year and a half, children from poor households, particularly from marginalized backgrounds, are rapidly forgetting what they had learned before the pandemic. New survey data suggests less than a quarter children from low-income urban families and just 8% among rural ones were studying online regularly as of August 2021. Show the finding published on Monday by a team of researchers led by economists Nirali Bakla, Jain, Vipul Pakra, and Ritika Khera. The team surveyed nearly 1,400 school children from poor households in 15 states last month. The survey reported no smartphone in the family for nearly half the rural people. Among those with one, the device was not exclusively for the child. Connectivity was poor and data was costly. There was little actual study going on, even for students lucky enough to be online. Among rural families with internet access, 43% parents said the school was not sending online material. Over 40% said the children found online classes difficult to follow. The result, over a third of children right up to class 4 could only read a few letters and could not read words or sentences in their own language. A majority of parents, particularly of children without internet access, felt the children's reading abilities had declined. Previous surveys during the pandemic have also reported learning setbacks, but the latest one comes at a time when children are preparing to advance 2 grades since their pre-pandemic levels, despite little evidence of learning. Epidemiologists have argued that in parts of the country, COVID-19 numbers are low enough to warrant staggered school opening with precautions. Next slide, please. This is the findings of the survey. most surveyed children studied offline and were deprived of teaching during the pandemic. And you see studying online regularly, only 24% in urban, 8% in rural. Dark red is urban, pink is rural. Live in a family with a smartphone, 77 urban, 51 rural. Top reason for children not studying online regularly in households that have a smartphone. His child does not have his or her own smartphone, poor connectivity, no money for data, child cannot understand online studies, no online materials being sent by school, especially in rural areas. And you see both urban and rural children in the survey struggled with basic literacy tasks. Next slide. Children from Dalit and Adivasi households suffered even more. Concerns about learning losses were particularly acute in households belonging to scheduled castes and the scheduled tribes. Around 55% children from these communities did not have access to a smartphone, against 38% among others in the survey. A finding confirmed by other surveys. Just 4% of children from marginalized groups were studying online regularly. As many as 43% were not studying at all, while the proportion among those from more privileged communities was 25%. As a result, children from the scheduled castes and tribes were nearly twice as likely as others to be unable to read more than a few letters. More than 80% of parents from these groups felt that their children's literacy had taken a hit during the pandemic. The effective literacy rate of scheduled caste and scheduled tribe children aged between 10 and 14 was as low as 61% as compared to 77% for others, prompting fears that achievement gaps might widen. Next slide, please. Other studies over the past year have shown similar losses of learning. India's school children had poor literacy and numeracy even before the pandemic, as recorded by the annual status of education report by non-profit Pratham. But the new survey adds to growing evidence that the pandemic has exacerbated these problems. A study by the Azim Premji University in January, covering over 16,000 children in 5 states, found overwhelming majorities of children between classes 2 and 6 had lost at least one language and mathematical ability they had when their schools got shut. Reading fluency suffered the most at lower grades and oral expression at higher grades. Last year, the child who was in class 3 is now in class 4, and the current session, very little has happened. One teacher from Madhya Pradesh told the surveyors. Next, the child will be in class 5. How can that child be brought to class 5 learning level? Mostly the situation is that some children have not even retained learning levels of class 3. So you can understand the gravity of the situation. Next slide, please. India has already had one of the longest COVID-related school closures. Now that India's pandemic school closures have extended into among the longest, experts fear that the learning losses will not be easy to reverse. A 2020 study by economists Tahir Andrabi, Benjamin Daniels, and Jishnu Das found that test scores of children hit by Pakistan's 2005 earthquake put them up to 2 years behind peers. This could even translate into 15% annual loss in their potential earnings for the rest of their life, a fate quite possible for the pandemic hit kids as well. Meanwhile, the August survey reported that parents, particularly in rural areas, strongly wanted schools reopened alongside fears over children's safety and mental health if they remained home. As older children begin to return to schools in some states, parents' eyes will be on primary schools to see if they open next. Next slide. Let's find out another epidemiological situation, that is the district-wise estimate of India's vaccination coverage. India has administered at least one dose of COVID-19 vaccine to 539.6 million people by September 7. In absolute terms, this makes India the largest country in terms of number of people who have received at least one dose of the COVID-19 vaccine. Comparable data from China is not available, but absolute numbers do not matter. What matters is a share of population which has been vaccinated. For example, Israel has completely vaccinated 5.5 million people, but relative to its population, this is 62.7% compared to just 17.7% for India. That is the proportion of fully vaccinated adults. International comparison of India's vaccination coverage is top 10 major countries by share of fully vaccinated people, and India on September 7, you see in the graph. with most decisions involving non-pharmaceutical interventions to prevent the spread of the pandemic, such as lockdowns, being taken at the local level, not just in states, but even district. It will help to know the share of the adult population that has been vaccinated across districts. HT has estimated the share of vaccinated population at the national and state level by using the population projections for March 2021 by the National Commission on Population. No such projection exists at the district level. So far, this has been an important handicap in assessing vaccination coverage at the district level. To be sure, the government is likely to have population data at the granular level, but this is not available in the public domain. Next slide, please. The next best estimate for district level wise population is number of electors and the projected adult population. COVID-19 vaccines are only being administered to people who are 18 or above. This means the database of voters could be a good proxy in India, the voting age being 18 years. The number of electors at the district level in the 2019 general elections available from the Election Commission of India is a useful data set. Data compiled by the Trivedi Center for Political Data, that is TCPD, maps assemble constituencies to district. This can be used to calculate the number of electors in these districts. There are a number of 662 districts in the TCPD database. HT has mapped 754 districts given in the government's COVID dashboard back to these 662 districts. Because these are 2019 numbers, adult population per district thus calculated is likely to be an underestimate by 3.74% of the projected adult population for 2021 at the national level. To be sure, there are differences across states. For instance, the number of electors is more than the projected adult population in Andhra Pradesh, Telangana, Karnataka, Odisha, and Tamil Nadu. In all other states, the number of electors is lower than the projected adult population. However, the estimation error is largely the same across states. Median deviation across the 23 states and UTs for which projections are available is minus 4.05%. Next slide, please. Second step is the best and worst performing districts. On the basis of the data on the electors, the share of adults who had received at least one dose of the vaccine by September 5 was 57.8%. The share of fully vaccinated adults was 17.6%. As expected, these figures are close to, but slightly higher than the estimated 55.7% with one dose and 70% with both doses, generated using the projected population. Population projections using electoral data show that top 5 fully vaccinated districts are Kolkata 76.1%, Diu 72%, Leh in Ladakh 71.7%, Gurgaon 64.3%, and Papunpai in Arunachal 59.6%. The 5 least vaccinated districts are all in Uttar Pradesh. Kanpur rural 2.97%, Badaयूं 4.35%, Kannauj 4.57%, Hardoi 4.67%, and Chitrakoot 4.75%. That is the area of concern. The best 5 districts by share of adults given at least one dose are Diu 210%, Kolkata 184%, Solan in Himachal 170%, Gurgaon 150%, and East Sikkim 149%. To be sure, these numbers could be bigger than 100%, not only because the adult population might have increased, but also because people from neighboring districts might be getting their shots here. The bottom 5 districts on this metric are Mehboob in Telangana 18.76%, Kanpur rural in Uttar Pradesh 20.2%, and Narayanpur in Chhattisgarh 20.14%, Senapati in Manipur 23.51%, and Kifere in Nagaland 24.36%. But best and worst districts do not capture the state's overall performance. The performance of the best and worst districts is not an indicator of the performance of their respective states. Kolkata, for instance, has delivered 4.2 times the number of total doses per 100 adults as West Bengal, and Gurgaon 2.3 times Haryana's. Kifir in Nagaland has delivered 0.45 times the number of total doses per 100 adults as the state. Kanpur rural 0.42 times as Uttar Pradesh. Narayanpur 0.38 times as Chhattisgarh. All these districts are among the top and bottom 10 districts by variation from state level vaccination figures. Vaccination in most districts are, however, close to the state level figures. The ratio of this coverage, district to state, the most, that is 60% districts, is in the range of 0.8 to 1.1. Next slide, please. The rural-urban divide in vaccination. You're seeing the graph, the vaccination coverage, rural, mixed, and urban districts. The rural is green, mixed is yellow, and urban is blue. Whether India's vaccination drive has reached rural areas is an important question. While using the number of electors as a proxy for adult population, HT has used total population figures from 2011 census to classify a district as rural. More than 60% population in rural areas, urban less than 40% population in rural areas, and mixed, that is 40 to 60% population in rural areas. Urban, mixed, and rural districts had 14.5%, 13.9%, and 71.6% of the total adult population on the basis of the number of electors. Not all states and union territories had all three categories of districts. For example, Bihar, only mixed and rural districts were there. Goa, only urban district. Up to September 5, the share of adults who had received at least one dose was 75.6% in urban districts, 61.41% in mixed districts, and 53.56% for rural districts. The corresponding numbers for full immunization are 28.01%, 21.36%, and 14.8%, as you are seeing in the graph. Next slide, please. Vaccine inequality across districts is high, but it is decreasing. A positive and a negative news is there vaccine inequality across districts. This analysis has been constrained by the non-availability of population data by districts. Such numbers are only available in the census figures, which are now 10 years old. Next slide, please. Inequality was increasing across districts until June, but it is coming down now. As you are seeing in the graph, the ratio of first dose coverage with coverage in top 25% districts and ratio of second dose coverage with coverage in top 25 districts. And you are seeing a change in the process. That means there is a decrease in inequality. Next slide, please. Laggard districts have higher overall population. While declining inequality in district-wise vaccination is a welcome development, it is quite high. What makes the challenge even more important is the fact that laggard districts have a bigger share of population than their top performing counterparts. For example, the bottom 25% of districts in terms of first dose coverage as on September 5 had a share of 32.5% of total adult population. This number was just 17.3% in the top 25% of the district. The same trend holds as far as median vaccination coverage is concerned. Districts below the median mark have 59% of the country's adult population. Next slide, please. Have districts pulled up or slipped down drastically? Have districts performing badly in the initial phase of vaccination shown a drastic improvement and vice versa? This is a possibility. Theoretically speaking, our analysis shows that this not very likely. Of the 157 districts which have been in the bottom quartile by share of population which has received at least one dose, only two, that is Morigaon and Lakhimpur in Assam, have managed to make it to the top quartile so far. The reverse also holds true. Only two districts, that is Janjgir, Champa, and Korea in Chhattisgarh, among the 157 districts which have been in the top quartile, have fallen to the bottom quartile. In coverage of first doses, 336 of 628 districts were in the same quartile on September 5 as they were on April 30, a month after vaccination was opened up for all adults. Among the rest of the district, 232 have jumped only one quartile, 112 going up and 120 going down. Only 56 districts have jumped two quartiles, that is 30 up and 26 down. And that is what is shown in the map of India down below. Next slide, please. Projecting inter-district inequality going forward. What will vaccine inequality look like if the current pace of vaccination in districts holds? Exact projections for the first two charts shown before would have been possible if the breakup of first doses by manufacturer were available. This is because the two major vaccines, that is Covishield and Covaxin, have different waiting periods between the first and the second dose. However, the number of total doses administered for 100 adults can tell us about the pace of vaccine administration in different districts. Here too, the gap is decreasing currently. The bottom quartile has, adjusted for population, administered doses among amounting to 40.3% of the top quartile. If the pace in all districts remain the same as the pace in the past 15 days, this will increase to 42.3% in the next 15 days and 43.1% in the next 30 days. So inter-district inequality will be less. Next slide. There were 13,000 excess deaths in Bhopal since COVID outbreak. There were 13,122 excess deaths registered by the Municipal Corporation in Bhopal since the start of COVID-19 outbreak from March 20 to July 21, which is 13 times the official number of confirmed coronavirus deaths, that is 995 in the city in the same time period. This means there were 12,127 deaths that may have possibly been caused by COVID-19 or other causes. In 2021 alone, there were 10,298 excess deaths in the city, a testament to the brutal toll of the second wave. Of this, 6,652 excess deaths were just in 2 months, that is May and June 2021, a time when the city's hospitals were overflowing with patients. You can now understand the amount of gap between the deaths reported and actual deaths. Next slide, please. The State Public Health and Family Welfare Minister of Madhya Pradesh said that while the situation was under control in 2020, when the Prime Minister announced a complete lockdown, in 2021, the second wave could not be contained with people caught off guard. He added that he was not aware of these numbers. Bhopal and Indore were places where the highest number of people reached for COVID treatment. They died while undergoing treatment, and family members cremated and buried them here in Bhopal. But the deaths were in hundreds, not in thousands. I will check the reason behind the high registration of deaths in Bhopal. So there need to be a collation of the actual occurrence of deaths of the individuals who belong to particular locations. Next slide, please. In the end, I would just appreciate your attention, and attention is the rarest and purest form of generosity. So I'm grateful for your generosity. Thank you so much. And before I close, I will take you to a video where our member Health Planning Commission talks about vaccine for children.
सर बच्चों की जो वैक्सीन है पहले कहा जा रहा था कि सितंबर के पहले सप्ताह से लगने लगेगी, उसको लेकर क्या स्थिति है, कब से शुरू हो जाएगी? और दूसरा, कई राज्यों में तो अब तो छोटे बच्चों के स्कूल भी खुल गए हैं, तो उन राज्यों के स्कूलों को क्या एडवाइस है? क्या अब सेफ है स्कूल खोलना, या जब वैक्सीनेशन हो जाए तभी खोलें? थैंक यू।
2 हिस्सों में देख लेते हैं आपका जो सवाल है। पहली बात है कि बच्चों को वैक्सीन लगे, किनको लगे, ये it's an evolving scientific and public health discourse. Only a few nations, or let's say limited number of nations, have introduced vaccination for children. As I said earlier also, there is no WHO recommendation that we should move in that direction for the reasons which we have explained here in terms of low mortality, etc., a high incidence of asymptomatic infections, etc. But the fact remains that we as a nation and as government are working actively in the direction of scientific validation of our vaccines for potential use in children. तो उसको जैसे आपको मालूम है Zydus वैक्सीन ऑलरेडी लाइसेंस फॉर चिल्ड्रन, हमें मालूम है कि इतना स्टॉक पाइल है, उसको अगर हम बच्चों पे दें तो किस तरह से दें, कब दें, कैसे दें, उसकी चर्चा हमारी साइंटिफिक बॉडीज़ कर रही हैं। कोवैक्सीन का ट्रायल बच्चों में बहुत क्लोज पहुंच गया है कंप्लीशन के। वंस वी हैव रिजल्ट्स, दैट वैक्सीन वुड बी पोटेंशियली अवेलेबल। अगर देना हो तो हमारे पास एक और चॉइस होगी। इसी प्रकार बायोई का वैक्सीन को भी परमिशन मिली है कि वो ट्रायल पूरा करें। नोवावैक्स, कोवैक्स को भी मिल गया। पहली बात तो ये अप्रिशिएट करनी चाहिए कि देश की धरती पर ये एक साइंटिफिक जर्नी सिस्टमैटिक तरीके से इस ग्रुप को वैलिडेशन के लिए, वैक्सीन्स की वैलिडेशन के लिए आगे अग्रसर हो रही है। दूसरी बात यह है कि फैसले का इंतज़ार करते हैं कि एक वैक्सीन अब अवेलेबल हुआ है बच्चों में पोटेंशियल यूज़ के लिए, डिक्लेयर हुआ है, उसके ऊपर हमारी एंटेगी हमें क्या फ़ैसला देती है। तो दैट इज़ समथिंग दैट वी वुड वेट फॉर। जो इशू आता है वैक्सीन से और स्कूल खोलने से, उसको हमें ये लेके चलना है कि स्कूल खोलने के लिए बच्चों को वैक्सीन लगे, ये क्राइटेरिया कोई भी दुनिया में नहीं मानते, क्योंकि स्कूल तब भी खुल रहे थे जब वैक्सीन का नामो निशान नहीं था. So that is not a criteria. No scientific body, no epidemiology, no evidence suggests that that is to be a condition. However, टीचर्स को वैक्सीन लगे, स्टाफ को वैक्सीन लगे, ये एक बहुत ही डिज़ायरेबल बात है और उस डायरेक्शन में बहुत ही कवरेज करने की कोशिश की गई है हमारे देश में कि टीचर्स को और स्टाफ को कवर किया जाए और हमें लगता है कि लगभग बहुत हद तक वो कवर हो गए हैं, जिस तरह से अभी रिसेंट पास में उस पर एम्फेसाइज किया गया है. इसके अलावा पेरेंट्स का टीका लगे ताकि बच्चे बाहर से लेके इन्फेक्शन आए तो कम से कम पेरेंट्स को वैक्सीन लगा हुआ होगा तो उनकी वो बचत रह जाएगी, वो उनको इन्फेक्शन नहीं होगी. तो वैक्सीन में बच्चों के लिए ज़रूरी नहीं, कोई कंडीशन नहीं, टीचर्स को होना चाहिए, हाईली डिज़ायरेबल एंड दिस इज विद इन आवर ग्रास्प. पेरेंट्स को लगना चाहिए, दैट इज़ विद इन आवर ग्रास्प. लेकिन स्कूल खोलने के लिए लास्ट में ये कहना चाहूँगा कि ये जो प्रक्रिया है ये सिर्फ एक हिस्सा है. ओवरऑल सिचुएशन एपिडेमियोलॉजी की सेफ होनी चाहिए कि संक्रमण रुका हुआ है, पेरेंट्स का साथ होना चाहिए एंड अबव ऑल स्कूल जब खुलेंगे उसके जो SOPs हैं कि बिठाना कैसे है, स्कूल का कमरा वेंटिलेटेड हो, खुले में क्लासेस हों, स्टैगर्ड क्लासेस हों, उनकी चेकिंग हो, मास्क पहना जाए, वो जो SOPs हैं दे आर ऑफ द मोस्ट क्रिटिकल इम्पॉर्टेंस और उसको साथ लेके स्कूल खोलने की प्रक्रिया साइंटिफिक दृष्टि से देखें तो संभव है और उसी तरह की अप्रोच हमें लगता है कि सब स्टेट गवर्नमेंट्स अपने अपने तरीके से ले रहे हैं. धन्यवाद.
Last question, 175.
Thank you so much.
Thank you, Dr. Rajiv sir. So with this, the evolving situation of COVID still tells that COVID is very much there, and there is a small evolution of the third wave in India, and rest of the globe they are witnessing fourth wave, and maybe because of the unvaccinated people or the breakthrough infections. But right now in India, we are still in a better situation. Only thing is, we all should get vaccinated as early as possible, so that at least our immunity becomes strong. And even if someone suffers, he suffers from a mild infection, and the hospitals, they are not required for, because last time in second wave we have seen that the hospitals and the healthcare infrastructure was overwhelmed with the cases. So vaccination is important, and this school opening is also very important, and this was a very important issue. So we have taken this issue last time with Dr. Lahria, Dr. Chandkan Lahria, who is a leading public health physician, and his views and the views of the member health, they coincide. They tell almost the same thing, that we should open up the schools, and vaccination of children is not that much important for opening of the schools. What is important is all COVID appropriate norms are being followed in the school, and all the teacher and the staff, they are vaccinated. The children, they study in the well ventilated classrooms, and this is very much important, because as Dr. Rajiv Saab told, that children's learning capabilities, they have declined over this period of last 1.5 years, and India, because of the lack of the accessibility to various gadgets for e-learning and for the virtual classes, they are not there. So a lot of our children, they have missed these classes, and they have missed the developing opportunities. So panelists, if they have any question, they can unmute themselves, or they can raise hands. I can request them to unmute themselves, and they can ask the question. Else, I would request Dr. Rajiv Kumar Jain sir, as you have rightly said that all 4 variants of concern, they are very much there in India, and the Delta variant, which was not that much prevalent in March, but it suddenly, because of its contagious nature, it has spread rapidly, and it has gone up to 90%. That was quite alarming in the month of May and June. And the same Delta variant is causing havoc in Europe and this US also. And in Australia also, the things are not in good shape. So evolution, a pandemic is evolving, it's still evolving, and we all need to be very careful. Dr. Rajiv Kumar Jain sir, if you have any other thing to speak,
No, I think the way things are evolving, this is only underscoring that it's a very dynamic situation.
Yeah.
And one needs to continue to be on guard. That means we need to continue adopting COVID appropriate behavior in our workplaces, in our households, in our environment, wherever we are moving, and not a single occasion we should give where we do not adopt COVID appropriate behavior in spite of being fully vaccinated. And also one should also remember COVID vaccines are not for stopping or reducing transmission or infection. They are not directed, they are not designed for that purpose. So this myth that person gets vaccinated can feel secure without COVID appropriate behavior is most inappropriate and should be removed from everybody's mind. And we in our community, in our workplaces, we must send this message very, very clearly. Vaccination shall not prevent infection. It will only prevent you from being hospitalized or prevent you from death. That is the only benefit the vaccine shall give, but not infection. You will continue to be infected and you will continue to spread the infection in spite of being vaccinated. And that is the primary reason one has to continue COVID appropriate behavior, I feel. If anybody in the panel, Dr. Srinike, Sanjay Rodithor, or Dr. Tyagarajan, or Dr. Puneet Chandna would like to express anything concerning epidemiology of COVID-19, they're most welcome.
Dr. Rajiv sir, I would like to request you to throw some more light on the new verification tool by Government of India. How it will help the the organizations like railways or Indian Oil Corporation. We all have the data of the employees and their mobile numbers. They are very much there, and we are in the process of compiling all the data with a dashboard about the vaccination of our employees. So in addition to that, how will this new verification tool will help us specifically, or it will help the other organizations where such sort of data generation is not there?
Right. Very interesting question, and this is important. Many people are actually seized with this idea how it will help them specifically. The major problem with verification and with actually knowing as to who has been fully vaccinated or who is not is the area of security, safety, and their data sharing. Any individual which enters a premise, if he has his mobile number is known, if he sends an SMS and the API is available to that organizer, say Indian Oil is having the API given by COVID, and you have your own database and you have your own mobile numbers. So you can verify as to who are the person who are fully vaccinated, who are partially vaccinated, and who are not vaccinated. The coding is in terms of 0, 1, and 2, not in terms of disclosure of full identity or full information, personal information of that individual. It gives a confidence amongst the people who are traveling that there is no loss of privacy. What is happening at times, the data or the certificate that were being shared, they were fake. people have started producing fake vaccination certificates. And there is no way the hotel or the railway station authority or the employer or the railway authorities or the bus station authorities would come to know whether the data provided, the certificate provided is genuine or not. And also it is a simple process. The use of OTP going and then verification by the employer or the workplaces or the airlines or the hotels is done in a very transparent but definitive manner. So whatever data you get, it is verified, validated through the COVID application. The biggest thing which Government of India has done, that is COVID National Health Authority, is making it free to all the employers, all the transport sector people, all the hospitality sector people, or any organization which wants to get this API. Thus, API integration with your website, with your existing tool, will help the organization to be more productive, more confident in actually moving the economy forward. That is the major benefit that this API with COVID is being provided.
Means false personification or false certification that can be cross-checked with this device.
Yes.
So, like for example, what you said, if I am visiting some hotel and they ask me for a vaccination certificate and I produce a certificate, but in turn they can verify it through OTP from the COVID portal.
Not only that, you don't need to produce a certificate. That you will not be required to produce a certificate.
Through OTP, they can cross-check.
Absolutely. And it'll be fully measurable and fully validated by the COVID application.
So I think government is doing a lot of things very meticulously and with the latest advances and in the digital technology and in the field of vaccination also and testing also. So government initiatives are quite organized, and we should cooperate with the government and the Government of India and the government authorities for vaccination, for testing, for following all COVID appropriate norms, so that this evolving situation is under control. And we know the gravity of the situation. We in India, in addition to the livelihood is also very important. So we need to be very careful and we need to be cooperative with all the statutory authorities. So
Dr. Sanjay Rotital wants to say something, I believe.
Yeah, good evening, sir.
Good
Wonderful
evening.
presentation. And actually your comparison with all statistics give us actually where do we stand as on today and in compared to the other world and other nearby countries. So it is really very good to hear all this from you and we get updated. Very nice. Thank you, sir.
Thank you so much for giving your time.
Thank you, Dr. Sanjay Rotito. So with this, Dr. Manish Singhal and Dr. Rajiv Kumar Jain, we thank you very much. If Dr. Tyagaraj has to say something, then otherwise we'll just Dr. Tyagaraj, you want to say something? You have raised your hand. Yes, sir. You have to unmute yourself, sir.
Okay. Hello.
Yeah.
Yes, you're audible.
Sir, one of the finest lecture you have given us, and to be honest with you, many of the things we were not knowing, and we really learned a lot today. And you have given us one of the best lecture today, and it was so nice and very elaborative and very knowledgeable and also very informative, which you have given. Thank you very much, sir. And it's a fully knowledgeable and fully thankful to you.
Thank you, Dr. Tyagaraja. And with this, we conclude this session, which went almost 2 hours. And this recording of this session will be available on our Enoch DigiConnect webinar YouTube. We have already 88 videos over there of the previous session. This will be the 89th recording, which will be available for all our members who and for the general public also who have missed this session because of their time constraints. So later on, this was live telecasted on the YouTube also. So we request you to refer to our YouTube channel and subscribe it also. With this, I thank you very much, Dr. Manish Kumar Singhal and Dr. Rajiv Kumar Jain for giving a very elaborative view about the COVID evolving situation and epidemiology of the COVID pandemic, and Dr. Manish for giving us an insight of the early detection of the of this lung cancer, how it is important, and how this new targeted therapies they can help even in the cure of the lung cancer. So thank you very much, both of you, sir. Thank you. We'll see you next week, for another session, 69th session at 6:30 p.m. Thank you.